Okay, so welcome everyone and hello. I'm Sherry Wells, Executive Director of the American Heart Association of New Mexico. We're so glad that you're all able to join us today for our robust conversation around COVID-19 and its impact on our community here in New Mexico. We have some incredible local partners who have helped make this event possible. And I'd like to give a big shout out to PNM and Albuquerque Business First. We appreciate your support very much. As we have several people, actually more than several, joining us, we're muting everyone's lines. Please use the chat box for any questions, and we'll do our best to get to as many as possible. We'll have time for a couple of questions after each speaker, and then there will be time at the end of our event for a question and answer period. We'll begin with our moderator, Matthew Jaramillo. Welcome, Matthew, who is the Government Relations Director for PNM. And we'll move into the panel discussion with our speakers, allow for questions. And then again, in case we don't get to all the individual questions, there'll be time at the end. We'll be closing by sharing resources for both you and the community. Thank you so much to our speakers for leading the conversation today. Joining us is Matthew Jaramillo, Government Affairs for PNM, who will be moderating our chat today. Dr. Mark Benars, interventional cardiologist, internal medicine, and echocardiography at Loveless Health System. He is also a member of our New Mexico board and more commonly known as Dr. B. Dr. Andrew Harrell, Associate Professor, Emergency Medicine, Department of Emergency Medicine at UNM School of Medicine, an American Heart Association New Mexico board member, known as Dr. Drew to all of us. We have Senior Vice President of Health Strategies for the American Heart Association from the Southwest region, Debbie Horner. And we have Dr. Denise Gonzalez, Medical Director of Adult Medical Specialties Program and Neuroscience Program for Presbyterian Medical Group. Unfortunately, our Lieutenant Governor, Dr. Howie Morales, had another engagement come up, and he's unable to attend today's discussion, but he was kind enough to send us a video link. Let's take a look.
Good afternoon. Lieutenant Governor Howie Morales here. I know that we'd much rather be meeting in person, but we've become accustomed to meetings just like this. I wanted to visit with you in person, live, but as we're preparing for a press conference today with the governor, I wanted to make sure that I at least had an opportunity to thank you for all the work that you do and you continue to do for people in the state of New Mexico. During my time in the state Senate, I carried many pieces of legislation that dealt directly with the American Heart Association and the impact that it had on people's lives. This was something that was very meaningful to me, whether it was STEMI legislation or legislation that would cost partners. It was important to us, and I have nothing but good memories with the opportunity to work together with many of you. This is also very special to me because my father recently, this past year, passed away from a heart attack. And knowing the impact that it had on all of our lives has been something that even motivates me more to work closely with your organization and to work with your causes to make sure that we make New Mexico the safest place to get care, receive care, and to make sure that we're treating our patients with the utmost compassion, highest quality possible medicine available, to make sure that we're doing all we can to save lives. So thank you once again on behalf of all the people of the state of New Mexico for all the work that you do for each one of us.
Wow, thank you to Dr. Morales for his unwavering support of the American Heart Association. That was a great video. Now let's get our panel kicked off with Matthew Jaramillo of PNM.
Thank you, Sherry, and thank you everybody out there joining us today. It is humbling to be available to moderate this panel of such esteemed folks that have really come together to help us navigate through a lot of this uncertainty. So we really hope that this panel really sets the stage, which is the first community conversation, the first of many that we hope to have. As Sherry said, I represent the Public Service Company in New Mexico, really building relationships, interacting with our federal, state, and local elected and appointed officials and kind of key community stakeholders, which has been a vigorous job over the last 3 or 4 months, considering a lot of the uncertainty and a lot of the turmoil that's been going on, not only in our state, not only in our nation, but globally. I'm a 16th generation Northern New Mexican, and I was raised to really believe that relationships are what invigorate and enliven our communities. And as we look at what many of us have been going through, a lot of uncertainty, a lot of hardship, as many of you know and have noticed, people have put a priority on their safety. And it's almost like we're in a survival mode right now with safety at the top of mind. And I think what we've seen, and this panel will most likely touch on, and conversations that we've had as we all trying to figure out what is a semblance of a new normalcy. How do we overcome this uncertainty? How can we figure out to be more proactive than we were before? How we can overcome some complacencies that we've had, really trying to work through and build these relationships, build our community up from the ground, and really try to make it prosper more so than it was before. And a lot of that's going to really deal with being proactive, especially with outreach and engagement. And I believe today's conversation is a perfect example of that. As you've seen with the wonderful panels we have and the leadership of our Lieutenant Governor, Javier Morales, and the leadership of our governor, we're really taking a lot of these proactive steps to keep people informed, to keep people engaged, and also hold people accountable. As you see around town, I'm in Santa Fe or I travel to Albuquerque, you see people starting to self-police themselves, starting to self-police others in the name of safety. And that is key, because if we see somebody that is acting indifferently towards the systemic issue that we're dealing with, we're going to have the courage and the leadership to make sure that we really help bring everybody along so we can overcome this uncertainty and really be more in a planning mode. And all that's really going to come down to how we share our practices and expertise. The panel is full of experts. They've had world-renowned practices, many of them, and this is just really the heartbeat of scratching the surface of where we can get to as a state. Proactive outreach, engagement, and really what this leads to, what I've always believed in throughout my entire career, building these relationships. And as we build these relationships, I'll go back to it. That is what's really going to bring our communities back into the forefront. We just got through a special session recently, and representing the business industry and the energy companies, planning has always been something we have been very, very good at. Except when you have something that is unforeseen, such as this, there's no way you can plan for it. And I think the leadership of our legislature over the last 4 or 5 days, the leadership of our governor and our lieutenant governor, the leadership of our fearless doctors, first responders, nurses, police officers, firemen, everybody, I think they deserve a very well-deserved round of applause and a thank you from all of us that aren't in that field, but really owe a debt of gratitude to everything that they've done. And I think today's going to be another thank you, so we can hear from them and what they've been doing and how they can teach us and educate us to be proactive, to help us install that outreach and really move forward as a state. And with that said, it is my pleasure, and I'm extremely excited to introduce our first panel speaker, Dr. Benares, who's with us today. He's going to walk us through the impact of COVID-19 on our cardiovascular care. And let's give from what I've learned, a Zoom social hello to Dr. Benares for joining us.
There we go. I was just looking for the unmute button. Thanks, Matthew. I appreciate that. I think that you can like clap for people with the little clapping hands that are somewhere that only my son can find on Zoom. So I really appreciate this opportunity to come and have a brief conversation with the community about COVID's impact on cardiovascular care and how it's impacted us locally. I just want to state the pride that I have in my state and the work that the governor and lieutenant governor have done in guiding us through this. I think that we continue to see the presence of the disease in our community, but it's not spiking up because we have had ingrained in us a culture of safety that I think has risen above politics. And I think that a lot of other states are politicizing safety really to the detriment of their populace. And so I'm very proud to be a New Mexican at this point and see the impact that our government's had on the penetrance of this disease and the impact to our state. I think we're doing a great job. And I want to just emphasize to the community the need to continue to wear masks, the continued need to stay socially distanced. This is how we are going to defeat this disease. It's very important. The impact of COVID that's occurred worldwide on cardiovascular care has actually been pretty significant, and it's not a direct impact from the virus itself. What we've seen is a detriment to patients feeling safe to come to the hospital. And so one of the things that, as we can disseminate the knowledge that the hospitals where people come for emergency care are incredibly safe. I'm wearing a mask right now because I'm at work. I stay masked all day, every day. When we take care of people that are coming into the hospital system, we're in N95s, and the government and the patients are masked. And really, this does give a huge margin of safety. The transmission of COVID is very, very rare within the facilities. And so the problems that people are not coming in for are adversely affecting them. And so we've seen higher STEMI mortalities. The STEMI is the large heart attack, the big one that people are ignoring. And so we've been seeing late presentations of heart attacks with all the commensurate problems that happen then from the late presentation, being heart failure, impact to the function of the heart, impact to the function of the valves. And we've seen higher mortality both locally, and this has also been written in the data worldwide, starting in Italy, and then all around the world we've seen an impact to people coming in with heart attacks that has nothing to do with COVID. We've also seen, interestingly, COVID's impact on heart care. And there are a lot of COVID patients that are presenting with cardiovascular complaints, namely heart failure, inflammation of the heart muscle. And so we've had to wade through that, deciding who needs to be taken for emergency cardiovascular care rather than who needs to be then supported for their respiratory care with the COVID in the hospital, and having a deferred management of their cardiovascular care. We have, through the American Heart Association, published guidelines for the management of ST elevation MI in the context of COVID. And so what we're doing right now, because we have to differentiate out between what is an emergent cardiovascular problem, what is the big heart attack, and what is a cardiovascular problem that's secondary to COVID, where COVID needs to be taken care of first. And so one of the things that we have done locally is do rapid screening based on patients' risk for being exposed to COVID. So do you have a relative that has COVID? Have you been directly exposed to it? Have you had certain symptoms, and have you had a certain travel history? And if patients answer yes to one of those, then we will transfer them after the management of their emergent cardiovascular disease to be ruled out with lab tests for COVID. If they answer no to all of our screening questions, and they have then on our heart catheterization the findings that are consistent with a heart attack, then we don't need to rule them out for COVID, because they're presenting with low risk and their findings on their heart catheterization are exactly as expected. And so we're managing those patients as we would anybody else with a heart attack. But the most important thing is that if you have chest pain, you immediately call 911. So what I call it on my slide is the disintegration of the STEMI care system of care. We've perfected care for heart attacks across the United States, and in a lot of ways, New Mexico has led in a lot of this because of our impact on all the furthest reaches of the state to take care of heart attacks in an expedient fashion. And we've impacted our mortality. Our mortality is half of what it was 10 years ago because of this. And so people need to continue to remain confident. I think I just lost this. Sorry, I just lost that for a second. People need to continue to remain confident in the care that they are going to get at the hospitals. The other impact that we've seen is in our care in the clinic, and we're continuing to do televideo visits, especially to patients that are coming from the high impact areas of the state. And I've seen COVID patients who we're effectively able to then follow up with at their homes through televideo. Televideo's impacted our practice and the efficiency of care significantly. We want to avoid packed waiting rooms. We want to be able to continue to care for high-risk patients with high-quality care at their bedside. So COVID-positive patients in the hospital, we're also doing televideo with. And so that basically is the impact that we've seen of COVID on our cardiovascular care and our practice and at the hospital. And I'd welcome any questions. I can kind of tackle some of these questions from the Zoom group chat. Let me look over these real quick. Thanks for the Sanford and Son, for appreciating the Sanford and Son reference, one of my favorites.
Hey, Dr. B, this is Matthew. I got one here that I think is right up your alley. The question is there a difference in the transmission rate between those showing COVID symptoms and those who are infected by asymptomatic?
The transmission, we don't know that. So the transmission rates are going to be based on your viral load that you have. And once you're positive, you've reached a threshold of viral load, that then is going to impact the significance of your symptoms. Of course, COVID is primarily treated through respiratory secretions. And so if you're actively coughing or sneezing, that's going to then impact the transmission more significantly because you're broadcasting your respiratory secretions more. But COVID can be transmitted by just talking, and so it's important to wear a mask, and it's important to stay socially distanced, to keep people out of, and really masks, the type of mask that I have on right now is protecting people from me more than it is people protecting than me being protected from other people. The N95 masks are the only ones that actually will protect you from other people. But if everyone's wearing a mask, then we are all protected because we're all protected from each other. So it's very, very important.
Okay, great. Thank you, Dr. B. And just maybe one more question following up on that. Noticing that we have a lot of spikes in our neighboring states, and it really hasn't hit New Mexico, but as our industry is starting to open up again, what would you leave us with? You've already said wear your mask, social distance, be cognizant of your surroundings. If you could leave us with one thing this afternoon from your perspective, what would that be that we can share with others?
So I would emphasize the importance of culture, and I guess that I referenced this earlier, but a culture of safety is so incredibly important. I drove my family out to Houston 2 weeks ago, it was pretty amazing to me, the difference as soon as we crossed the state line, where people just were not wearing masks. And it's really and it is interestingly through government leadership early on that I think the New Mexicans are very, very confident in this culture of safety that we've created here in our state. I'm very proud of it. And I talked to a patient today who was in Phoenix who said the same thing. And it really has to be exactly that we have a culture of safety. And when somebody, in industry, if you have people that are visiting from areas where they don't have that same culture, your local business needs to emphasize it. I've been to a couple of local breweries that are beginning to open up, and they're being incredibly responsible with contact tracing. Register for contact tracing. Make that something that you lead with. You know, they're being very, very responsible with social distancing with the tables that people are sitting at. And the culture then translates to us leading with not getting frustrated as those rules are emphasized by the local businesses, and encouraging them, because it's harming to the local businesses to enforce these rules, but they're doing it effectively.
Great. Thank you so much, Dr. B. We really appreciate it. And I think we couldn't reiterate more. We've heard it once and over again. We're all in this together. And I think it takes that culture of safety and that leadership to really take action, be proactive to make sure that we're making sure everyone is safe around us. So really, thank you so much for those words of wisdom.
Great. Thanks, Matthew. Thank you, Sherry.
Sure. Up next, we have Dr. Drew. Dr. Drew, thank you so much for being here today.
Matthew, thank you so much, everyone. And I'm gonna touch on some similar themes that my good colleague, Dr. Bernars did. So thanks, Mark, for setting up an easy lob over here to me. I'm gonna about 5 minutes or so, and then obviously take questions as well. So if I can have the next slide, Davida. So this is, and I think I can't reinforce enough what Mark was talking about. So, you know, for the last now almost 2.5 months, while we've been under a state of declared public health state of emergency, we have seen, I'm sure Mark and any of us on the call as well in the healthcare field have had a particularly very early on, very precipitous decline in the normal health presentation complaints that we've seen. And in the emergency department, we've noticed a significant decrease in people presenting for emergencies that are still going on. And I think it's important, as Mark said, with the disintegration of kind of the systems of care that we've worked very hard to put into place. I want to reinforce for people that the risk associated with contracting COVID-19 in a healthcare facility where we are taking all of the appropriate and recommended steps, wearing masks all the time, really working to develop and cohort patients that are presenting with specific symptoms. The risk associated with contracting COVID-19 in an appropriately controlled healthcare setting is far lower than the risks associated with the everyday emergencies, the heart attacks and the strokes and the overwhelming infections, the sepsis that we've seen. The overall mortality for those disease processes is much higher than the mortality rate for COVID-19, which will be somewhere, we're now kind of prognosticating, but even if it's 0.5% to 1 or 2%, that's still much lower overall. And Mark, any of my other colleagues can comment on the fact, than not getting treatment for an infinitely fixable disease process or easily a attenuatable disease process, because you're worried about getting a viral infection in the emergency department. If you're worried about getting a viral infection anywhere, then you would never leave your house. And I think it's important to reinforce for folks that the emergencies that go on a daily basis are still a much greater risk for you and for your family members and for the community than it is for the COVID risk in the now what is only 4 or 5 months into this global pandemic. And that's really important, because we don't want to see a terrible story like we have here, where a 38-year-old man that if they presented into the emergency department and I called Dr. Bernars and clearly had an intervenable cardiac problem related to a blockage in one of his heart blood vessels that Mark could fix, that waited because they were worried and then didn't get timely care and ends up with really long-term complications, or even worse, as happened in this case, ended up dying from a heart attack. That in this day and age, we have a well-tuned system developed for dealing with this, just like we do for strokes and overwhelming infections and any of those other things. So that's really important. Don't forget that the emergencies that are still happening are likely much greater risks to you and your family members in the community than it is from COVID-19 infection, taking steps appropriately to care for yourself. So first point. Next slide, please. So, and I think this is, as Mark touched on, again, what we have asked and what we have been very fortunate for here. We were one of the earliest states in the country with good direction from our elected officials and an organized approach to keep the community safe, is that protecting yourself is protecting the community. And I want to reinforce that because we've talked about masks up in the upper left-hand corner. If you needed to know, roughly a cow is 6 feet from people. So if you can't have a good reference, always think about your dairy cows for those of you that have them around. And then hand sanitizers and good hygiene. But it's important, and why that is, I think, the important part for people to remember is that when you don't get the disease, as Mark said, or you don't spread the disease yourself, and I want to bring up one thing that Mr. Jaramillo said, is that the real big risk, once you start to develop symptoms, you have an inclination that you likely are coming down with any viral infection. The real big risk, and where masks and good social distancing and good hand hygiene come into effect, is that pre-symptomatic phase where you are not yet developing the body aches and the fevers and the chills associated with it. If you don't have a mask and you're out in public and you're not taking appropriate social distancing guidelines, then you are at a much higher risk of spreading that disease to those that you're meeting out in public or around your family, or those at work if you're out in the community. So it's important. And the top right-hand corner with the bed space availability is the single biggest thing, because for those of us all following the appropriate recommended guidelines and taking steps to protect ourselves and to protect our family members and our community, really provides a cushion for those of us in the healthcare field, because when we run out of hospital beds, as we were concerned about early in this disease process, when the very early movement by the governor and the rest of the elected officials to implement the declared public health emergency wanted to help us guard against overwhelming our healthcare facilities. And I just want to, we've been doing this a long time. I understand that it can become, we can grow weary of this, but many of the healthcare facilities, mine included at the University of New Mexico, is still running greater than 100% capacity in our ICU beds, even now, months into this. And we don't want to overwhelm a facility or even a system and really put ourselves in those terrible decisions where we have to make hard choices about who gets what. And that starts with an individual, with each of us taking the right steps to protect ourselves with good hand hygiene and protecting the community. Next slide, please, Davida. And the final one, and I really wanted to, the last two slides are my pitch for everyone to still don't let off on the gas. This is an important time. We've, I think Mr. Jaramillo mentioned the fact that, we're seeing surrounding states having increased cases occurring, Texas and Arizona and other places, and even California, that was very early on in terms of making sure implementing appropriate social distancing and putting in protective measures. Because if we end up not following the appropriate public health recommendations, which is wearing masks, doing good social distancing, making sure you're doing good hand hygiene, we end up with a loss of the protection down to the individual level. And these, it's difficult for me to understand where no one, I think, in this day and age believes that the public health recommendations about wearing a seatbelt and wearing a helmet when you're in a car or riding, skateboards or outside, and not drinking and driving, all of those things have been shown to make a difference. And mask wearing during a pandemic event clearly has been shown to help decrease the overall rate of spread. And the infection, the R0 value that we've got there on my slide here really shows you. So we're looking at a disease that for every one person infected spreads it to 3 people, and very quickly can have large community spread rates, particularly in condensed settings. It's really important for people to look at and think about things that are being recommended that are simple and easy to do. And just like Mark, I wear a mask the entire time that I'm at work now, just a normal, simple surgical face mask. And that likely will be the case for us in healthcare for quite some time. And it's important to be mindful of that and think about those things from a public health perspective at the population, making sure that you're giving protection to you and your family members, and through that to the community. So with that, I'll take any questions or wait until the end when we're doing it. Thank you so much, Sherry, and I appreciate everybody being here. And Matthew, thank you for providing the good moderation for it.
Sure thing, Dr. Drew, and thank you so much for that information. Before we continue, I just want to thank one of our great friends, our Honorable State Auditor, Brian Colon. He's not only the most photographed man in New Mexico, but now that we have Zoom, he's the most videoed man in New Mexico. So let's give him a nice welcome, and thank you for joining us, Auditor Colon. The first question I have, got in, Dr. Drew, is what is the guidance from CDC or New Mexico medical examiners to determine if COVID-19 is the cause of death, given that so many people with underlying conditions are in such jeopardy? Is the guidance the same as it is for the flu or diabetes?
Yeah, Matthew, so thank you, and I appreciate whoever asked that question. So the current CDC guidelines would indeed currently probably mirror what is recommended for the influenza or any other infectious disease process. What the current recommendations are for death determination in cases where anyone has been found to be COVID positive and ends up succumbing from that disease or a sequela of the disease, is that likely COVID will be a contributing factor, but that won't be the primary cause of death. But for instance, let's say that someone that ends up with a pneumonia after getting a COVID infection and then goes into hypoxic respiratory failure and eventually dies from that, will have COVID-19 as a contributing factor as the cause of death on the death certificate. It would be in essence no different than influenza, which would be another disease process. In terms of hypertension, diabetes, COPD, those would likely be contributing factors, but those would be pre-existing medical conditions that would be noted on the death certificate, but they wouldn't be direct contributors to it. The COVID-19 or influenza or any other infectious disease process, per the current CDC recommendations, would likely be noted as contributing to the cause of death.
Okay, great. Thank you, Dr. Drew. And then I got another question, and it's one that I've kind of heard somewhat widely debated. How often do you feel that PPE or N95 masks can be safely reused?
Well, I will start with a disclaimer, is that none of this obviously would be approved from the manufacturers, and you have to do this on a case-by-case basis in terms of what is the best recommendation. But if you have a safe way, as many places have done, to look at reutilizing and particularly re-sterilizing, particularly N95 masks, and that was a concern very early on. Doing so with the appropriate input from whatever agency or entity you're working with, making good, informed choices is the best way to do this. I will offer, in terms of what our current practice is that we, within the university health system, are issued an N95 per time that we need one. And then those are utilized in a particular situation where there is high risk exposure. So this is different than just the normal surgical face mask that Mark's using. So the N95s are placed on us when we are in large risk exposures. So aerosolizing generating procedures, so things with invasive airway management or ongoing cardiac arrest with CPR and assisting with ventilations. Those are placed, and then over that we place a surgical mask on top of that to provide another layer. We are utilizing our face masks until soiled, and that's a visual soiling, or I believe it is a total of 3 consecutive days, at which point in time we will dispose of them and then be reissued another one. We only use our surgical face masks once one shift, and then those go away, and if they are soiled at any point in time during that shift, we replace them, as the case may be. Because we, in an infinite world with unlimited resources, we would certainly only be using a mask once at a time, but that would very quickly run out of resources for those of us that need them, with good informed utilization in the procedures where we know we have a high risk exposure for it.
Great. Thank you so much, Dr. Drew. And thank you, and Dr. B, thank you as well for everything that you've done for our state and for everybody that lives here in New Mexico in these times of truly an uncertainty of what our future looks like. Now let's spend a few minutes looking at the impact the American Heart Association is having against the fight of COVID-19 on the community. And for that, let's turn to Debbie Horner. Thank you, Debbie, for being here.
Thanks so much. And I really want to take the opportunity again to thank PNM and Albuquerque First so much for your support in bringing this conversation together along with the American Heart Association, and just so appreciate the expertise that Dr. B and Dr. Drew are sharing with us. I think what we have found as we're convening conversations with partners across all of our 6 states in the Southwest, we're finding that it's so valuable to take the time to have conversations in our communities about the specific context, the specific circumstances that we're dealing with, all of us locally, and to be able to track the most current developments as we all work within these unusual times. So thank you all so much for joining us today. I think this has been just an extraordinary time for the American Heart Association, as it's been for all of us really in communities. And I think part of what we've experienced is that within the environment of COVID-19, there are some challenges that we were already facing, and particularly when we think about the impact of cardiovascular disease and stroke. We knew that we already had an uphill battle to climb, but we've been making some good progress in different ways. With the onset of COVID-19, I think we saw certain challenges really exacerbated within this environment. And we've really seen at the community level, some of those, folks with underlying conditions have been disparately impacted by COVID. We've seen important realities when it comes to the challenges that members of our community have in getting access to healthy foods, getting access to medicine. We've talked a little bit today about access to healthcare. And then we've got the reality of the incredible stress that everyone's been under in these changing circumstances and the economic impacts of COVID-19. So we've really seen what are some difficult and challenging circumstances that already existed really heightened. So we've talked a lot over the past few months at the AHA about how the work that we all do together is more important now than ever. As we go to the next slide, we wanted to share with you all today a little bit about how we have responded and sort of pivoted at the AHA, trying to make sure that we're really leveraging some of our longstanding and existing assets that the American Heart Association has in order to immediately respond to some of the specific challenges that we've all been facing. So, research has always been a cornerstone of what we do. And with the generous support of communities across the country and organizational partners like PNM and Albuquerque First, we have been able to invest incredible amounts of resources into research to address cardiovascular disease and stroke. With the onset of COVID, we were able to pivot really quickly to establish a $2.5 million rapid research fund to track scientific research to better specifically understand COVID and its interaction with cardiovascular and cerebrovascular disease. We were able to really get that research out the door, that funding out the door and in play immediately so that we could respond to COVID. Another exciting asset that we were able to leverage has been a partnership with the Lawrence Livermore National Labs, utilizing a protein atlas that was developed through the American Heart Association Center for Accelerated Discovery. And this has been used to help speed discovery of therapeutic antibodies or antiviral drugs for the virus that causes COVID-19. We've developed a searchable data portal that's available to share this COVID-19 research with scientists worldwide. And the portal houses a wealth of data it's gathered from ongoing COVID-19 molecular design projects and some really exciting work that's been done around the world to design drugs to fight the virus. Another response that was so urgent for us is appreciating the work that our frontline healthcare providers like Dr. B and Dr. Drew are dealing with and fighting on our behalf. We really wanted to respond with meeting the needs of healthcare providers in this changing environment. One of the things that we did right away was to utilize our existing Get With the Guidelines data registry, which is a quality improvement registry, to add modules and pieces that would capture COVID-19 data elements. And this is really helping hospitals and medical centers to better manage current patients that they're treating today, specifically within the context of COVID, while preparing for research studies to improve how we'll treat patients prospectively in the future. So we look at the next slide. One of the other really long-standing supports and assets within the AHA has been our work to both develop guidelines for CPR and to implement trainings across the country. And so we worked with partners quickly, a couple leading health organizations, to update our CPR interim guidance to help those who were rescuing or treating victims of cardiac arrest, really to assume that those that they're responding to have COVID-19. We needed to update those guidelines to keep people safe as they were providing CPR. We were able to pivot and do that really quickly with collaboration from other leading healthcare organizations. We also established a website with CPR training related resources and information, and we're using social media campaigns to encourage individuals to focus on using hands-only CPR if they encounter a victim of cardiac arrest. Another really exciting approach to addressing resuscitation has been an initiative that we call We Can Help. And this is really leveraging a virtual CPR training program that we just began over the past 2 years that provides what we call low dose, high frequency training for CPR. What we found was in the beginning of COVID-19, while we were both updating CPR guidelines, we also looked at extending the timelines for which folks who were getting certified, we wanted to give them a longer period of time to complete their training so that they wouldn't lose their CPR training cards. We knew that there were going to be challenges for folks to make sure they were able to update their training. What we actually heard back from hospitals and healthcare partners was that they didn't want to delay that training. And so we've been able to offer our virtual training through our We Can Help program as a free resource to hospitals for whom it might have been a challenge financially to pay for the program otherwise. This has really allowed systems to sign up for our training solution that's called Heart Code Complete, free of charge, and it's provided them with some really valuable resources. So in our 6 states, over the past 3 months, we've had over 11 hospital systems that have committed and have implemented the We Can Help program, and that's impacted over 880 healthcare workers, and it's provided a little bit over $110,000 of free educational resources to our partners. We've also been trying to leverage, again, our online resources for the faith community to be able to integrate COVID-specific information into existing platforms so that we could continue to educate folks within the faith community and in partnership with other community-based organizations. Then we go to our next slide. We know too that other environments that we all interact with on a daily basis, thinking about some of the conversation we've had today about how businesses respond in this environment, we've really worked to update some resources that we could provide both to schools and to employers that again would provide them current information that could help employees and kids stay healthy. I know that for myself included, I've had my kids at home over these past many months, and it's been really important for parents to keep their kids both active and healthy. So part of what we did was to quickly develop through our Kids Heart Challenge program an initiative called Kick Cabin Fever to the Curb. It's a 10-day challenge that's designed to really get kids up and active and also continue to educate them about health. And we've had about 1,200 schools across our 6 states participate in that initiative over the course of March, April, and May. And then, when we think about the work that we've been doing at the community level, We've been working across our states and different communities in collaboration with other terrific community partners to do things like respond to immediate food insecurity needs, providing immediate access through CSA food boxes and other mobile market solutions, with an eye toward building sustainable responses to address access to healthy food. We've been convening conversations like this within communities with other terrific partners, just to make sure that folks have the information and resources that they need. We had a very exciting conversation, really led by tribal leaders in different communities across our states just over the last month, to again think about what are the culturally specific solutions and approaches that tribes across our 6 states are taking, and then thinking about as well within the African American community, within the Hispanic community. We've been engaging leaders in those communities to talk about some of the very culturally specific approaches that communities are taking to stay healthy and safe during these circumstances. And I think that's my last slide. We want to make sure that folks know that as we're highlighting these resources, all of this work is possible only through your support and collaboration. And as you hear about some of the things that I've highlighted at a high level, please don't hesitate to let us know if we can provide you access to any of these resources. I know we'll be doing some follow-up after this call just to make sure you know how you can get at some of these resources and information. But again, want to thank all of you for your partnership in helping to keep our community safe.
Thank you so much, Debbie. And before we go to the couple questions I have, it looks like we have a lot of new friends on this call. Would you remind everybody on how we can access those resources, how we can get more insight to all the wonderful work that the American Heart Association does? You're wonderful at communication, but just remind us where we can go to find a lot of this information.
Sure, it's very easy to, just to visit heart.org for overall information about the AHA, but we also have a specific web address, heart.org /coronavirus, for all of our sort of curated resources specific to COVID-19. And then we'll make sure we send you out some links to other resources in follow-up to the call, particularly for folks on the call who are part of the healthcare community. We have developed a really robust compendium of resources for healthcare providers, including interviews and resources with and from healthcare partners really around the world.
That's great. Thank you so much for that. So I got a couple questions. The first one is, what is the effect of sunshine on the virus?
Well, I'm definitely going to defer those to the experts, either Dr. Drew or Dr. B. I think that those gentlemen can probably respond most appropriately.
Yeah, Debbie, so I'll take a stab, and certainly Mark can chime in, but just looking at it, so unfortunately the disease, the virus will actually live, and if you look at CDC guidelines, it can live in the perfect situation on the perfect medium, wood or metal or some such. You can have it there as long as 7 days, depending on what that disease, what the virus particles is on, could contribute to it being there shorter. But I think it's really important to reinforce. So things like sunlight, so UV light is one of the ways that you can sterilize and kill the virus. And obviously, the appropriate percentage of Clorox solution or any of the Oxivir wipes or other types, not making a statement against for or against anything, but there are plenty of commercial products out there. The important thing is to be mindful of, if we're not spreading the virus particles and we're not putting it onto surfaces, we don't have to worry as much about those being there to be passed on to the next person that touches it. But that's where it's really important, from the good standard public health measures to protect yourself, is wearing a mask and don't touch your face and eyes, and good hand sanitizing, washing your hands or using hand sanitizer will decrease the time frame and the amount of virus particles that might be on any given surface. And if you're in high traffic areas, so we have been encouraged I'm sure as many people are doing now, to make sure, so things that get touched a lot that you never think about, but right, light switches and doorknobs and pull knobs on dressers and on cabinets, and any number, elevator buttons in elevators, for those of you that work in them, taking something that you don't have to put your finger on the button to choose your floor can go a long way to decreasing your overall risk of exposure, because if you have a virus particle that might be able to live for a day or two, and many people are able to get exposed to it, that can just further that, passing on of the disease process with the virus is picked up. So just be mindful of it. But if you aren't spreading it, or you're taking good known steps to protect yourself, then you're going to minimize the spread and protect yourself and your community and your family.
Great. Thank you so much, Dr. Drew. And thank you so much, Debbie, for giving us the big picture of what's happening in research and supplies and policy with the American Heart Association. We really appreciate all your work. And finally, and definitely not least, we have Dr. Gonzalez. Let's turn things over to you, Dr. Gonzalez. Thank you so much for joining the conversation today. It's a pleasure to have you.
Good morning to everybody, and thank you very much for your kind invitation. I am truly honored. And much like Mark, I'm very proud of our state's response and proud to currently serve the state as one of the Central Command Center medical directors. We've been responsible for developing the system of triage in case we needed to ration scarce resources. Thankfully, because of our great state's response, we haven't had to do that, but we're continuing on in our work. My focus today will be on telemedicine and on safety. And to give everyone my disclaimer, I'm just a critical care doctor, and I'm a nerdy engineer for some of you who know that about me. So I hope to not get too geeky on you. Historically, CMS requirements for telemedicine really restricted services to rural zip codes. And for this reason, we only performed tele-ICU and tele-NICU, and we limited ourselves to our own facilities. Services to Espanola and to Clovis were billable. However, when we covered Rust Medical Center in Rio Rancho for tele-ICU, that was not a billable service based on CMS rules. Some national companies performed telemedicine, but they would contract directly with hospitals and didn't bill payers for their services because they couldn't. But the pandemic response and the CMS waiver changed all of that. Under the waiver, we've been able to use telemedicine more broadly. In fact, we've used the same technology to minimize exposure to infected patients. We've essentially repurposed telemedicine to an infection control system. Because visitation was extremely restricted, we also use that technology to improve family communication. Tablets were and are being used to bring family members into the room to see their loved ones, whether or not they have COVID infection, because today they still can't enter the hospital. In fact, I've used the Doximity platform to bring family members into the room for a code to see them as they're receiving CPR. And I've used Skype for daily updates to family members and to obtain consent for procedures. In the ambulatory world, it was even harder to perform telemedicine because of the requirement to be in a healthcare facility. This made direct-to-consumer telemedicine nearly impossible. Pre-pandemic, we were performing clinic-to-clinic consultation for endocrinology and doing remote interpretation of sleep studies and EEGs. Post-pandemic, under the CMS waiver, we've been able to deliver direct-to-consumer telemedicine in nearly every specialty and in primary care. We're hopeful that CMS, and as a consequence, commercial payers, will continue to reimburse for direct-to-consumer telemedicine. Patients love the ease and convenience. In fact, our patient satisfaction scores and our no-show rates are the best they have ever been. Some care can always be done virtually, like diabetes management. Some can never be done virtually, like a pelvic examination. And in between, there are a lot of opportunities for us to care for patients differently. We're very focused on keeping patients safe. We've followed the state's playbook for reopening as we transform our clinical operations from pre-COVID to our new normal post-pandemic. Use of telemedicine is just one of the many strategies we've used to protect our staff and to keep our patients safe while still providing excellent care. When the pandemic started, we strongly messaged for people to stay home, to self-isolate, to self-quarantine if symptomatic or exposed. And you've heard a couple of presentations already about how that has had some unintended consequences. Patients started to defer care that we never intended for them to delay. For example, heart attacks, strokes, and non-elective surgical care. We want patients to know they should feel confident to seek medical care in our facilities. We've put in physical barriers for your protection, such as sneeze guards. We have screening processes and sanitizing stations at our entrances. We use appropriate PPE for your protection, and we practice frequent cleaning and have installed systems to cleanse the air to minimize the risk of infection. Please seek care if you need it. We promise to care for you where, when, and how you need and expect it. And thank you again for your invitation, and I'm glad to answer any questions.
Great, thank you so much, Dr. Gonzalez. Again, we all want to thank you for everything you've done during this very difficult time for a lot of folks. I think technology and telemedicine is really something our state has needed for a long time. Just unfortunately, it takes a situation like this to really put it at the forefront of everybody's mind. I got a few questions for you. What connection are you seeing, if anything, with neurology and COVID-19?
Yeah, I think that there was a lot of initial literature, perhaps linking presentation of strokes in unexpected populations to the COVID infection. I think we're going to have to wait and see what the epidemiology bears out in terms of the relationship between COVID infections and the presentations of various illnesses such as coronary artery disease and stroke, pulmonary emboli, deep venous thrombosis in patients that we don't typically see them in. I think it's too early to really say for sure one way or the other.
Okay, great. And the second question is, do you think telemedicine will be more accessible going forward after the pandemic, particularly for rural areas around New Mexico?
Yeah, so I have my ongoing hope. I think that when Ms. Varma has spoken in terms of CMS continuing to cover telemedicine, I think that there is some hope. I've gone to testify at the federal level in the past to see if we can evolve it. The government has been pretty conservative, but I think that when they take the lens of the entire country, they tend to forget about small rural states like our own. On the other hand, I think that our state has been very progressive and understands the importance of covering such services. I know that Secretary Scrace has been very committed to continuing to cover, in particular for patients under the various CMS programs, to continue to have telemedicine and telephone encounters as a means of receiving care.
Matthew, if I can, I think I want to piggyback on Denise's point, because this is perhaps one silver lining in a very terrible situation where, and tongue in cheek, like we shouldn't let a good pandemic go to waste. And we have worked very hard, as Dr. Gonzalez can well attest to, putting in kind of stopgap measures to allow us to do this distance outreach telemedicine. And we really can, I think, leverage this to show that it makes a difference. It keeps people in their communities where it's appropriate and allows people like Dr. Gonzalez and Dr. BNRs that might be able to telemedicine consult at a location either across town or even across the state. And though Dr. Gonzalez, we are a small population in a very large state. That can go a long way to minimizing needless transports and needless movement of patients that could be cared for in their hometown where they can be supported by their own families, which makes a huge difference, as we all know. And I think it's really important for everyone here to be mindful of the fact that we really need to continue the work to keep this telemedicine initiative that we've been able to put into place due to public health emergency declarations with a pandemic moving forward, because I think the benefits for that will be shown across the system and can continue even once we get back to whatever our new normal will look like.
Absolutely, Drew. I'm glad you picked up on the fact that I was trying to present this as this is the silver lining to COVID. Before, the things that were impossible are now possible, and we're doing them. And we need to continue to spread them even further.
Indeed.
Great.
Mahesh, Allison, make sure that y'all are listening.
Well, thank you both. I have another question for you, Dr. Drew. This one came up. How long does the virus stay on the mat?
Did you say stay on the mat, Matthew?
On the mask.
Oh, on the mask. Okay. So I think it's probably safe to say that in perfect situations, you've probably got, a few days. If it is perfectly positioned where you're not, I actually take my surgical face mask that we have to wear when we come out of the hospital. I actually put it on the dash of my car and leave it on the dash of my car in front of my sun visor. And if any of you that I think all live in New Mexico know, with 320 plus days of sun a year inside a windshield in July, there's plenty of both UV light and temperature to help decrease the likelihood that that's going to survive in any way, shape, or form. But I would assume that you could have that if you look at the CDC recommendations. If you're curious as to specific materials, if you just type in how long does COVID live on surfaces, you will pull up a wealth of information, and I would direct you towards known sites for obviously the Centers for Disease Control and Prevention, the National Institutes of Health, which will do it on there. But we have anywhere from as short as 4 hours on things like copper surfaces that impart some degree of antiviral protection, and maybe as long as 7 days on certain things like some wood or plastics. It's important to be mindful of that, and that's where good hand hygiene and good public health measures, where you're wiping down high traffic areas and high traffic touch surfaces on a regular basis, can help you with that.
Here's another question, and I'll open it up to the three of you, related to kind of do's and don'ts of home treatment. If you have COVID, but you don't have severe symptoms require a hospital visit, what are the do's and don'ts of self-care in the home?
So, I would say staying in touch with your symptoms, and respiratory symptoms are going to trigger the need for advanced care first. And so shortness of breath with COVID should trigger you being evaluated, because shortness of breath can then progress to the ARDS, significant inflammatory problems very quickly. But home care should also then cause you to be isolating yourself from your family. And so home care can be very, very logistically difficult. And I have 4 little kids, and they all want to be all over me at all times. And so it'd be very difficult, honestly, to be at home. Our friends who actually have self-isolated at home have stayed in a camper, have stayed in their casita, and I have a friend who's gotten a hotel room. It becomes very logistically difficult, but you can't assume that your family has it if you have it. And so continuing the protective things that we do at work, like wearing a mask if you have it, and then continue to wash your hands at home, and keeping the things at your home clean, just as you would in public. I think that's the essence of home care. And then, frankly, depending on your work return policies, we really should be testing negative before return to work. So.
Great. And we have two more questions. This one, again, open it up to all three of you. What have you learned about whether patients can get COVID twice? I've heard that this week that a patient had it in February and then now has it again.
I'll take a stab at that, Matthew. So, this is a novel coronavirus, but the coronavirus is not a new family of viruses that the human population have been infected with over the course of time. And as anyone that has had the common cold twice during any given season, we don't yet have enough information to know, do you have some imparted immunity, whether it's full or partial from a previous infection? But plenty of us have gotten multiple common colds during the course of one general, season, fall, winter. And so I think it's important to not assume that if you have had it, that you are somehow miraculously protected from getting it again, because small mutations in the virus, as it continues to circulate in the population, can certainly create a situation where you might get another infection. You might have some protection, but I think would anyone want to get the flu twice in the given season? I mean, it's awful if you have it once, and I would want to take all of the appropriate safety measures to not get it, and certainly to not get it again if you ended up with one that caused you to have significant symptoms and obviously had you at home for a week or two, as the case may be. Denise or Mark, I'd love to hear y'all's, but that's my general gestalt is I wouldn't assume that if I got it once, I'm like free and clear. I'm out going, we're out in the world doing like we were back in, last July.
I think there's a lot of questions as to the significance of convalescent, antibodies after infection, and whether there actually is immunity. I think that we've seen this with the antibody responses that have tried, the antibodies that have tried to be isolated from patients for therapies, that there is varying degrees of viral neutralization from the antibodies. And so I think there's still a whole lot to be determined about the actual immunity to the virus. I think Drew's response was spot on with that.
Yeah, I just wanted to say that I secretly hoped that I was in fact infected with coronavirus in January, and that was going to be my golden ticket. But that was a false hope.
And Matthew, we've got one question. I think we've got a participant that had a question about they have a child that has congenital heart disease. I hope I am making sure that I'm looking at CHD correctly.
Yeah, I was just starting to type a response to that, actually. Okay. And I'll tackle this, and I think we can all probably chime in on this. But I think partly it depends on the type of congenital heart disease. If there is significant shunting, or if the child is hypoxic, then the impact of lung infection would be much more significant. I don't think that it's known, except for retrospectively, why certain patients have greater impact, like hypertensives, except the fact that hypertension then is the marker of greater impact of systemic disease, obesity, why more young people with obesity end up with more advanced disease. Maybe it's that they can't clear the respiratory system as well. But congenital heart disease doesn't necessarily tie right into a more significant COVID infection. And the COVID infections in children have, even the Kawasaki-like disease that's occurred in children tends to clear itself, and the children, and even when they require ICU care, most do okay and have few persistent effects. So I think this is a good example of where universal precautions for prevention are needed. So all of my children have little masks that they wear in places. My children wash their hands. And so I think a kid with congenital heart disease should also engage in the same universal precautions.
Yep, and I think to echo Mark's point is if you had a structural defect that was easily corrected early and there's really no long-term systemic complications, then again, very likely to have a low risk. And children in general, less than 18, have a very low rate of hospitalization and a very low rate of significant disease burden complications. But I think it's really important to make sure everybody understands, though, is that they are significant vectors because they have such low complication rates and might not have very many, if any, symptoms at all that they can contribute to the spread. So if you've got little masks and keep them on your children and keep their hands clean like Mark can, that is 100% the way to go, because as we continue to try and appropriately open society back up to some extent, we have to make sure we're mindful to protect against increasing case occurrence rates as we are seeing in the surrounding states, and the impact that can have for us as we move through the summer and into the fall with the reoccurrence of the normal disease processes from influenza and other respiratory viruses can be a concerning compounding on patient occurrence rates and presentation rates in facilities that we really want to make sure we are mindful of.
Drew, I want to correct the misconception that I have clean children. My children, they just wash their hands.
Apparently they mind well. How about that?
And then just from the critical care standpoint, this is a novel virus, but when we see the flu, when we see novel influenzas, like when we had H1N1, we have very similar observations. Patients who are obese, patients who have diabetes, patients who have these various underlying diseases don't do very well. They do poorly. They're the ones who progress to ARDS, who are much more difficult to ventilate. And so, yes, there's some novelty to this coronavirus, but there are also some common denominators in the presentation of critical illness between this coronavirus and everything else that brings patients into the ICU.
Great. Thank you so much, Dr. Gonzalez. And then one final question, if you could leave us with one thought that would really provide advice to our community, what would that thought be as we wrap up? Dr. Gonzalez, do you mind going first?
Sure. I think that it's important for all of us to not let our guard down and to continue to function as one unified state that understands that when we each as individuals participate in a common purpose, that we help ourselves and everyone around us.
Thank you. Dr. B?
That I would continue, regardless of your politics, to support the government efforts because they've been successful, and you know I think that we as healthcare providers and people interested in the health aspect of this really have to be advocates, saying that we are doing the right thing. I'm one of the most frustrating things during this entire time was the politicization of government and the impact of government. This is where the government has to stand up and take leadership, and we have. So.
Thank you, Dr. B. Dr. Drew?
Yeah, thanks, Matthew. And again, really appreciate being able to participate and being asked to impart some knowledge. I think the things that I want to send people home with are wash your hands, wear a mask, do appropriate social distancing, and remember we got this, but we've only got this as a state and a community working together to try and protect all of us from something that we know with really simple procedures and processes can keep all of us safe. So with that, wash your hands when you're done and wear your mask when you go outside.
Great. Thank you so much. And I really want to thank Dr. Howie Morales. Unfortunately, you couldn't be here again. Dr. B, as always, Dr. Gonzalez, Dr. Drew, and Debbie Horner. If we leave with anything today, I think all of you said some very poignant things. Leaders need to be leaders. We need to enrich and install a culture of safety. Protecting ourselves is protecting our community. And most importantly, we need to utilize our partnerships and alliances, whether it's through telemedicine, whether it's utilizing technology. And I think Dr. Gonzalez and Dr. Drew, you said it best. If there is a silver lining in any of this, not only is it telemedicine, really reaching those that need it most, but I think it's the ability to look at something in a different way that we've seen and known that has been an issue, but now really to put action behind it. And most importantly, I really want to thank the American Heart Association community, especially Sherry, Davita, and Amy for all the work that you do. It is amazing with the staff that you have, the difference that you make here in New Mexico and the lives that you enrich. We really hope that you continue with this community conversation. I think it has done wonders for this topic, and I hope we can carry that forward. I am honored and humbled to participate with everybody here, especially you and your team. So thank you all very much, and I hope you have a wonderful day. Sherry? Sherry, I think you're on mute. But
there we go.
Really
how's that?
Things about me.
Thank you. Can you hear me now?
Yes.
Okay, thank you. Thank you, Matthew, again. You're an awesome moderator. You made some great observations for us. And thank each and every one of you for your time and expertise today. I don't know if others feel this way, but I feel like we could keep talking and engaging. And I'm just really proud to be part of American Heart Association, that we can be a convener and hope to do more of this type work in our community. I want to reiterate what one of the earlier participants, but one of the chats that said, we're so fortunate to be in a community and a culture of safety over politics. So thank you again very much. During this time of social distancing and many people working from home, the American Heart Association would like to ensure we're providing value to our communities in many ways. We'll be sending you information following this call on 3 key themes: mental health and stress, physical activity at home, and eating healthy at home. I don't know about you all, but I'm running out of ideas for recipes, so I always enjoy the healthy eating tips and recipes. We'd like you to share that information with staff, coworkers, family, and friends. And additionally, you'll find more resources at heart.org/coronavirus. We are also working on giving people opportunities to stay active and stay connected. To learn more, you can go to our Facebook page, American Heart Association New Mexico. And again, I just want to thank our sponsors again, to PNM, for being such great sponsors, such great resource for our communities, and also our award-winning media sponsor, Candace Beakey, and her team at Albuquerque Business First. They'll be holding a virtual event called The Future of Healthcare with Conversation Pods on July 15th. The pods will include aging, data, technology, resilience in workforce, and you can get more information on their website. With that said, again, thank you so much to each of our presenters today, and thanks to all of you that joined. Thank you, Matthew, for moderating, and together we can be a relentless force for longer, healthier lives. Good day and stay safe. Thank you so much.